Sir, if I may ask a question, sir.
Yes, sir. Please, sir.
Sir, this is the first case presentation is for 1 hour, isn't it, sir?
Sir, usually, sir, but it is a short case, can be 45 minutes to 50 minutes.
Okay.
Second
Okay.
one is a longer case.
Long case. Yeah.
Yes, sir. Yes, sir.
Okay, sir. Sir, if I may ask a question.
Please, sir. Right. So, warm welcome to all of you. It's 8 o'clock.
8 o'clock.
One moment, please.
1 moment, please.
Mani sir, good evening, sir.
Yeah, good evening.
Nishi sir, good
How are
evening,
you?
sir. All good, sir. All good here. Warm welcome to all of you for this Friday evening session. We have two important exam cases for the day. We have a case of oral cancer and we have a cancer of malignant right upper quadrant mass. The first case will be presented by postgraduate of Professor Rahul Khanna sir from IMS BHU Varanasi, Dr. Sai Venkatesh. The second case is kindly contributed by Professor Amit Gupta, AIMS Rishikesh. So this is going to be Dr. Monisha. So we have very eminent faculty panel for the day. Professor C.S. Mani from AMCC of Chennai. Professor Rudracharya, again, she's from Shalimar, Delhi. And we have Venkateshwar from Cancer Institute, Adyar. And we expect Dr. Anil Heru to join us shortly. And thank you all for joining us today. And I request Dr. Nishikant to conduct the proceedings for the evening. Thank you, Nishi sir. Dr. Sai, can you please share your PowerPoint, ma?
Yes, sir. Is the screen visible, sir?
Yes.
Good luck to you, ma. Please go ahead. Nishi sir,
Thank you.
please take it. Yes.
Yes.
So myself, I'm Dr. Sai Venkatesh, third year postgraduate resident from BHU Varanasi. I'm going to present a case on oral ulcer, moderated by my guide Professor Rahul Khanna sir, and the head of the department is Professor S.K. Bharti sir. A 49-year-old male, former by occupation, hailing from Varanasi, came to BHU surgery OPD with a chief complaint of multiple white speckled patches in oral cavity from 2 years and an ulceroproliferative lesion in the right lower gingival sulcus from 8 months, and a complaint of multiple swellings in the right cervical region from 3 months. The history of present illness as stated by the patient. He was apparently asymptomatic 2 years back when he noticed multiple speckled white patches in the oral cavity, and which were insidious in onset, gradually progressive, and multiple painless patches involving the buccal mucosa, and ulceroproliferative growth in the right lower gingival sulcus from 8 months, which was insidious in onset, gradually progressive, initially from a 0.5 centimeter in size, which currently attained a size of approximately 3 centimeters, and it is not relieved by taking any treatment. The growth was associated with the mild, intermittent, dull aching pain over the growth from 8 months, which is non-radiating, aggravated while chewing food, and relieved by taking analgesics. There were multiple swellings in the right cervical region from 3 months, which were insidious in onset, gradually progressive, not associated with any pain, ulcer, and discharge. There is history of loosening and fall of teeth present, and the patient lost all of his teeth 3 years back. And there is history of difficulty in opening of mouth and history of difficulty in mastication present. There is no any history of difficulty in speech, no history of bleed or pus discharge. There is no history of excessive salivation, no history of any other ulcer or growth in the oral cavity, neck or body. There is no history of dysphagia. There is no history of trauma or dental intervention. There is no history of any hoarseness of voice or recurrent sore throat. No history of ear, nose, throat related complaints, and there is no history of any high risk behavior, loss of weight and appetite, and no history of any metastatic symptoms. Past history, there's no history of any comorbidities and no history of any surgical intervention in the past. Family history, there is no history of any similar illness in the family members or no any history of malignancy related deaths in the family. Personal history, patient takes mixed diet and he has history of tobacco chewing in the form of gutka from the past 40 years, and he also gave a history that he keeps the gutka in right lower gingiva buccal sulcus, and he's a non-alcoholic and non-smoker, and he has a normal sleep-wake cycle with normal bowel and bladder habits, no history of any drug allergy. Summarizing my history, the patient is a 45-year male who is a chronic gutka chewer, came with multiple speckled white patches in the buccal mucosa from 2 years, and there is a slow progressing ulcer proliferative lesion in the right gingiva buccal sulcus from 8 months, which was associated with mild dull aching pain while chewing, and multiple swellings in the right cervical region from 3 months with difficulty in opening of mouth and mastication.
All right. Doc, can you give us some anatomical explanation for that symptoms that you're suggesting? Can you go back to the summary slide? This is easier to follow.
Yes, sir.
Yeah. All right. So let's start from the last word, mastication. So there is difficulty in mastication. So what do you think is the underlying anatomy or the physiological problem there?
So the patient has lost all his teeth, sir. So one of the difficulty in mastication is due to that, and other reason is involvement of the tumor muscles of mastication and
So
associate.
what are the muscles of mastication?
So muscles of
Are they the
mastication.
same as the muscles involved in opening of the mouth, or are they different?
Yes, they are same, sir.
So what are the
And
muscles?
so muscles include medial and lateral pterygoid, the temporalis, and the masseter, sir.
Very good, very good. And what about the dull aching pain?
So the dull aching pain is due to the nerve infiltration itself and associated any infection or irritation of the
What nerve
ulcer
are we
proliferative
talking
growth, sir.
about? Which nerve are we talking about?
So it is a sensory nerve endings of the mucosa, sir.
It will be. What is the sensory supply of the mucosa there?
So in the mucosa, it is by mandibular nerve of trigeminal.
So a branch of the trigeminal. Okay, fine. That's also a good answer. What about the swellings in the right cervical region?
So swellings in the right cervical region suggest you of lymph nodes, lymphatic metastasis.
Okay, so multiple swellings would be, what would be the anatomical levels in the neck that you will want to?
Sir, I will check for lymph node levels in level 1, level 2, level 3, and level 4, sir, which are the level 1 include the submental and submandibular triangle. Level 2, 3, and 4 are upper, middle, and lower jugulogastric group of lymph nodes.
Okay. And what about the other levels?
So the other levels include posterior triangle level 5, sir, and central group of lymph nodes is level 6, and level 7 is upper mediastinal group of lymph nodes, sir.
So for a problem like this, which started in the buccal mucosa, do we have any kind of understanding about which levels could possibly be involved? You're saying multiple swellings.
Yes, sir.
In the right cervical region. So where should you look for those multiple swellings, and what will make you worried, and what will be expected lines?
As per the patient complaint, the growth is involving the right lower gingivobuccal sulcus, which is a lateralized disease. So I would expect ipsilateral group of lymph nodes of level 1, 2, 3, and 3 will be the first exams. Sometimes skip metastasis may also be present to level 4. So.
Very good, very good. So you absolutely your understanding of the anatomical basis and things are excellent. Okay, so when you go on to examining this patient, you need to kind of confirm whether this understanding is actually appropriate or not. Okay, that is
Yes,
the idea about physical examination.
within.
All right. So is there anyone else who
So,
wants to add a question or two?
just I wanted to ask, you have written chronic gutka chewer. So, what
Yes, sir.
other forms of tobacco is used in India?
Sir, other forms include quid, sir, kaini, and pan masala. Sir.
Yeah. So you have to take little detail history, because you see that also is a guide where you will find the ulcer. If they are putting in front of the incisors, that might be just in the behind the lips. If they are putting on the lateral side, then it is more chances of having near the gingivobuccal sulcus, and that is why the history of everybody will say gutka, but you have to just pinpoint what type of tobacco they are taking. That is one point. The other point is, why did you write multiple speckled white patches?
Sir,
So this is related to the ulcerative lesion, or this is separate?
no, sir, it was a separate lesion, sir, all over the buccal mucosa. Patient has
So
a
what is the
previous.
cause? What is the cause, and how do you ascribe them?
So, multiple white patches from past 2 years in a Gutka chewer might be leukoplakia, or a pre-malignant lesion.
Okay.
Or
I think
So,
you're
So
going
what are-
overboard to say it is speckled white patches, doc. You should say white patches, which is agreeable. You know, nobody will come and tell you I have speckled white
Yes.
patch. Okay.
yeah.
Yeah.
Venkatesh.
Dr. Sai, good evening.
Venkatesh.
Yeah,
yes, sir.
Dr. Sai, good evening.
Good evening, sir.
You told about difficulty in opening the mouth and mastication, and I also
Yes,
want
sir.
to know, he is having these symptoms for the past 2 years, but what brought the patient now to the hospital? Why did he come to the hospital now?
So
Does he
because
have pain or
sir, it's because the ulceroproliferative growth, even though it's present from 8 months, it gradually developed from the 3 months, the multiple right cervical swellings and the difficulty in opening the mouth.
so difficulty in opening the mouth brought the patient to the hospital?
Yes, sir, and associated cervical swellings. It was main complaint.
Great, great. And what is the reason for difficulty in opening the mouth? What are the possible reasons for difficulty in opening the mouth? What do you call that in scientific terms?
Sir, in medical terms, it's called as trismus, sir.
What
And
are the causes of trismus?
causes of trismus include the also malignant growth itself because of its desmoplastic reaction and oral submucosal fibrosis and involvement of the muscles of mastication or temporomandibular joint. And other benign causes include sort of peritonsillar abscess and mm, the eruption of wisdom tooth and
Good. Which is
Good,
the
good.
most common muscle involved in trismus among the masticator muscle?
the lateral pterygoid.
Medial pterygoid. That is the
Medial
nearest
pterygoid.
muscle to the retromolar trigone.
Correct.
Sir, we can carry on with the. Sir, do you have any other question?
Yes, sir.
Dr. Sai, what are the grades of trismus?
So grades of trismus, it's based on the interincisor distance. If it is more than 35 mm, then it is grade 1. And if it is between 26 to 35 mm, then it is
How do
grade
you
2.
clinically assess it?
So clinically, it's a number of fingers that can be possible. So that if 3 fingers, then it is adequate. And if it is between 3 to less than 3 fingers, then a score of +1 is given. And if it's only 2 fingers can be incorporated, then a score of 2. And only one finger is incorporated, a score of 3 scores.
What is leukoplakia by definition?
So, leukoplakia is defined as any white patch that cannot be rubbed off and it cannot be characterized either clinically and pathologically.
What are the types of leukoplakia?
Types include a homogeneous or a nodular leukoplakia.
Other types?
Other other types include erythroleukoplakia.
What is erythroplakia?
Sexual, so,
What is erythroplakia?
so erythroplakia is a bright red velvety patch or plug that cannot be characterized as clinically or pathologically any other lesion.
Just now we told that different etiological factor. How tobacco causes malignancy? How pan causes malignancy? How gutka causes malignancy? What is the role of betel nut? What is the role of lime?
The tobacco as itself has many carcinogens, around 400 to 500 carcinogens.
Okay, very good.
All among them, there are nicotine, polycyclic aromatic hydrocarbons, and nitrosamines. All these they cause DNA mismatch repair mechanism by which leading to dysplasia and malignancy. And the betel leaf and uh, areca nut, they contain aracolin and tannins. Aracolin causes the stimulation of fibroblasts and fibrosis, and tannins cause the stabilization of the collagen fibers, resulting in oral submucosal fibrosis and further development of dysplasias, malignancy.
How do you classify carcinogens?
So
WHO, any
carcinogen,
classification is there?
sir, I am not towards. I don't know about
Class
the
1, class
classification.
2, class 3, class 4 are there. I just want to know, sir asked three etiological agents, tobacco, areca nut, and slaked lime.
Yes, sir.
Among these three, are they all class 1 carcinogens? Class
No,
1
sir, I
is
don't.
definite role for carcinogen. That is the definition. They have a definite role. So is tobacco as a class 1 carcinogen?
Yes, it should. Sir, I don't know about the classification, sir, but tobacco itself is a major risk factor for
Okay. Is
carcinoma
areca nut
carcinogenesis.
a class 1 carcinogen?
So it's actually it causes a pre-malignant lesion, sir, oral submucosal fibrosis, by which then it so it's a primary hit for the in the process of carcinogenesis, sir, but it itself does not cause carcinoma.
That is what we also thought 5-6 years back, but WHO has now reclassified areca nut as a class 1 carcinogen. So that is the point I want you to understand.
Okay.
So does he have pain, Dr. Sai?
Yes, he has mild intermittent dull aching pain, sir, that too, which is intermittent and aggravated while chewing, sir.
Is the
At the
pain a feature of
ulceroproliferative
advanced
growth, sir.
cancer or early cancer?
So pain is a feature of advanced cancer, sir, because of peripheral nerve infiltration, bone erosion.
Can be both
Apart from
ways, Dr. Sai. You can have some referred otalgia even in early stages when it comes in a different subsite of the oral cavity. So let's not be too dogmatic about it. Yeah. So we take pain
But-
is just pain and related to the clinical examination.
So as Dr. Mani pointed out, I just wanted to ask you about referred otalgia.
So referred otalgia is due to infiltration of the tumor, the lingual nerve infiltration, sir, due to which the pain is referred to the ipsilateral ear because of similar nerve root sharing by the auriculotemporal nerve.
If it's in the posterior 1/3, where will be
So
the
for
pain?
so if the posterior 1/3 is by glossopharyngeal to tympanic plexus, so middle
If it's in the pharynx or larynx?
and the pharynx or larynx in the 10th cranial nose.
Auricular branch of vagus. Yeah, you feel a dull aching pain near the
Posterior
post-auricular
auricular.
region.
Okay.
So these three are very classical pathways. You might be asked regularly in the examination. Prepare a chart just before the exam and blurt it out. I
Okay,
think we
sir.
should go to the examination, sir.
Yeah.
Okay. General examination. After taking informed consent, the patient was examined in a well-lit room in a sitting posture, and he is conscious, cooperative, oriented to time, place, and person. He's moderately built, nourished, and well hydrated. And his height is 153 centimeters with a weight of 48 kgs, and BMI is 20.5 kg per meter square. And his ECOG performance status scale is 1. And vitals, there are no pallor, icterus, cyanosis, clubbing, and pedal edema. Temperature is febrile. Pulse rate is 84 beats per minute, regular, normovolemic, normorhythmic, measured in the right radial artery. Blood pressure is 114 by 86 mm of Hg, measured in supine position in right arm. Respiratory rate is 16 per minute, thoracoabdominal in nature. Coming to examination of oral cavity and neck, on inspection, the facial symmetry is distorted and there is a solitary oval swelling of 3 into 3 centimeters over the inferior border of body of the right mandible with the overlying normal skin surface. Mouth opening is restricted, only 2 fingers can be incorporated. There's poor orodental hygiene and halitosis was present. These are the clinical photos showing the swellings on the right inferior body of mandible, and this is a intraoral growth in the right buccal sulcus, as well as multiple erythroleucopenic patches involving the right buccal mucosa as well as the palate. Lips are normal. There is loss of dentition. The diffuse erythroleucopenic patches all over the buccal mucosa and oropharynx. The gingivolabial sulcus is normal. The gingivobuccal sulcus on the right side, there was an ulceraproliferative growth of 2 into 2 centimeters with everted edges and the base is covered with slough, extending around 1 centimeter posterior inferior to the right commissure and 2 centimeters anterior to the retromolar trigone, 1 centimeter superiorly from the sulcus onto the buccal mucosa. There is no any active discharge or bleeding from the ulcer. Rest of the buccal mucosa, hard and soft palate, uvula shows multiple small leukoplakic patches. The tongue, floor of mouth appear normal. There is no any restriction of tongue protrusion or no deviation of tongue. On palpation, the inspectory findings confirm, and there was a solitary ulcer proliferative growth of 2 into 2 centimeters with ill-defined margins and this hard, immobile, non-tender base involving the right lower gingivobuccal sulcus and the underlying body of mandible. Mandible was edentulous, and there's no any tenderness, and the growth does not bleed on touch. Surrounding induration of 0.5 centimeters is present around the ulcer. The gingivolabial sulcus and the floor of mouth was spared. The retromolar trigone is normal. There was a solitary oval, immobile, hard, non-tender swelling of 3 into 3 centimeters present over the inferior border of body of right mandible, extending 2 centimeters anteriorly from the angle of mandible and 4 centimeters from the midline, with pinchable skin over the swelling. Multiple small, firm to hard, mobile, non-tender lymph nodes of around 0.5 to 0.5 centimeter palpable in the right cervical region of group level 1, 2, 3, and 4. And the trachea is present in midline. Bilateral carotid pulsations were normal. The cranial nerves examined 7, 9, 11, and 12 are also normal. A systemic examination, the CNS, CVS, respiratory systems are within normal limits. For abdomen examination, soft and non-tender with no organomegaly present. Summarizing my case history, there is a patient is a 45-year male. Is a chronic gutka smoke chewer with multiple speckled white patches in the buccal mucosa from 2 years, with a slow progressing ulcerative lesion in the right lower gingivobuccal sulcus from 8 months, which was associated with mild dull aching pain while chewing and multiple swellings in the right cervical region from 3 months with difficulty in opening of mouth and mastication. A 2 into 2 centimeter ulcerative growth present in the right lower gingivobuccal sulcus extending into the buccal mucosa and the right mandibular region as a hard, non-tender swelling at the inferior border of body of the right side of the mandible with multiple leukoplakic patches in the buccal mucosa and decreased mouth opening with right cervical lymphadenopathy present involving the levels 1, 2, 3, and 4. All these findings suggestive of a neoplastic etiology. So, my provisional diagnosis of this patient will be the carcinoma involving the right buccal mucosa and the right lower gingivobuccal sulcus with right cervical lymphadenopathy of levels 1, 2, 3, and 4. The clinical staging will be C, T4A, N2B, and M0. The stage would be level 4, stage 4E.
So Manish starts.
Doc, that I'm very concerned about the swelling which you're talking about on the inferior border of the mandible.
Yes, sir.
Do you have any assessment about the mobility of that node?
So the swelling was not mobile, sir. It was fixed to the underlying mandible, sir.
It is not mobile and you feel it is stuck to the bone.
Yes, sir.
So what would that swelling be?
So that swelling would be the infiltration of the primary itself, sir, into the mandible, sir.
Is that what you're thinking? So how would that, you mean to say that disease from the gingival sulcus is traveling along the mandible and it is presenting in the inferior part of the mandible, is it?
Sir, because the patient was edentulous, there will be that through the alveolar sockets, the tumor cells might have infiltrated. And the other route will be the direct eroding into the bone.
Can it be anything else, though?
Else into the bone marrow invasions
What
are
will,
through.
can you tell me what will be the anatomical relationship to that swelling from the perspective of the neck? What will be the structures which are anatomically related to the swelling? Bone,
At,
I'm assuming you're talking about mandible.
yes, sir.
What are the other structures? What are the other structures?
So at this region, from the submandibular triangle, the facial nerve and facial artery and the facial vein enter into the face.
Right? Then,
So
so
other
what constitutes the submandibular triangle? What are the
it is
borders?
so the borders are the anterior and the posterior triangle, so anterior and posterior bellies of the digastric, with superiorly the inferior border of the body of mandibles.
Very good. So there's such a large swelling situated there. What are the other contents of this triangle?
The other contents include the submandibular glands and the lymph nodes in those regions.
And is there anything else in that area?
So,
Is there any nerve, any
sir, it branch of facial nerve is present, so the marginal mandibular nerve.
okay. What else?
Sir, and lingual nerve is present. Sir.
Okay, what else? Is there any other nerve you can think of?
No, sir, I don't
If
think
I say there is hypoglossal nerve also situated there, will you disagree with me?
no, sir. Hypoglossal nerve, yes, sir. It's supplying the tongue muscles of tongue. It has, yes, sir.
So you agree with me. Okay, so there is a swelling. Let me argue that you're right, that the disease is tracking down to the submandibular gland directly. All right.
Okay, sir.
So if it could get attached to the bone, what prevents it from getting attached to the nerves there? And what should you have been examining properly?
Sir, for nerves have the sheaths are epineurium and perineurium, due to which.
No, don't get into those details. You want to clinically know whether these nerves are involved or not, isn't it? Because all
Yes, sir.
these are contents of the same triangle.
Yes, sir.
So in one part, it is affecting the bone. It is getting attached to the bone or probably eroding the bone, according to you. If it
Yes.
can erode into the bone and then you're
No,
not able to move it, it could also erode into other structures. And the
yes,
other
sir.
structures, vessels, you may
Nerves.
not be able to palpate well, but nerves you should be able to clinically examine. So what are the clinical nerve examination you did?
In this, at this swelling, sir, initially the marginal mandibular nerve, sir,
Did you
which
examine it?
supplies the platysma of the neck.
Did you examine the nerve? How do you examine the marginal mandibular?
Sir, by asking the patient to contract the neck.
What do they contract? What will they contract?
So the platysma agnes.
How will they contract the platysma and what is the supply you're going to? Facial nerve and platysma is how you examine? What are the methods of examining the facial nerve? Tell me. All the branches of the facial nerve. What are the branches of the facial nerve?
So initially from the trunk, the upper and the lower divisions includes the temporozygomatic as well as the facial cervical branch.
Very good. Okay.
The temporal
So
side.
how do you examine each of the branches of these two nerve divisions?
Sir, by closing of the eyes, sir, and asking the
So
patient.
anything above the eye you want to examine?
Yes, sir, the wrinkles, forehead, sir, for asking wrinkles of the forming or not.
What muscle
Sir,
is that? What muscle are you testing?
frontalis muscle, frontalis is the
Very
muscle.
good. In the eye, what muscle are you testing?
Say orbicularis oculi is for
Very
eye,
good.
and for the closure of the mouth, orbicularis oris, and for asking the patient to smile, which the muscle examined is levator angularis.
Very good.
Levator.
What is the nerve supply to that?
Sir,
Right? What
the
is the nerve
marginal
So,
mandibular. Marginal mandibular is for levator angularis. The
so
cervical branch is for
if you think marginal mandibular supplies that, why would you want to um, contract the platysma? What would you do now?
So ask the patient to smile and clench the
Yeah,
teeth,
yeah, smile well. That's what you're going to pick up
as
from
well as
the marginal mandibular. Yeah, so you should do that. Why would you want
puffing
to?
of
So difficult to make a person contract platysma, isn't it?
yes, sir.
Yeah. All right. So what about the other nerves?
So the other nerves
Why did you
include
not
the
examine in this case?
lingual.
Why did you
Sir,
not examine this case for that? Why did you not tell in your examination about this?
sir, I have said about the cranial nerves. I have examined the 7, 9, 11th, and 12 cranial nerves.
Oh, like that you say. Okay. What test did you do? That's what we were interested.
So for the 7,
How will you
for the
test the
9th,
ninth nerve, and why would you want to test the ninth nerve?
so 9th
There is no
now we
rational for me to think that ninth nerve should be examined in your case. So why would you want to examine the ninth nerve?
right now is a glossopharyngeal. It supplies the sensory innervation of posterior 1/3 of the tongue, sir.
But
So if
we are
any
not talking
lesion,
anything about. No, our lesion is not extending to the floor of mouth or the tongue.
no, sir, not
So
the tongue.
why
Yes,
are you interested in the glossopharyngeal nerve? You are not meant
so
to be
if
examining there.
yes, sir, if in our patient is not even extending up to
We are talking about
neither
your
the retromolar
patient.
tree.
We are not cutting and pasting from a textbook, right?
Yes,
We are
in
talking
our
about your
patients,
patient. Not relevant, right? You
not
agree with
relevant.
me?
Yes, sir.
Okay.
Yes.
What is the other nerve? You said 10 also. Did you say 10? Which are the other cranial nerves you said?
Sir, the cranial 11 and 12.
11 and 12. Okay. So why would you examine 11? What relationship has this swelling to 11?
The spinal accessory nerve is content of the triangle in the neck, the level 2 as well
Does
as the
it
level
come in
5.
the submandibular triangle? We are talking about the submandibular triangle, right?
Yes, sir.
This swelling is not
Not
transgressing the
really.
submandibular triangle, correct?
Yes, yes, sir.
Whatever he examined in the level 2 was only 0.5 centimeter nodes.
Yes, sir.
Is that correct? So
Yes,
why
sir.
would he examine 11th nerve?
So 11 now, so all these nerves, if base of
No,
skull
in your
involvement is
case, what made you examine the 11th nerve? You can examine
in
even
our
optic nerve,
case, yes, sir.
isn't
In
it?
our case, it was
We are
not
not talking
necessary.
about that. So it's
In
not
other
relevant.
words,
Not
relevant.
necessary.
You tell the relevant findings. It unnecessarily deviates the case, isn't it, Dr.
Yes,
Sai?
sir.
So if you get into problems like this, then it is very difficult to come out of it. So there is a node along the facial nerve region. You stick to it. 9, 11, 12 are nowhere near there. So that's what Sir is trying to nail the point. Fine. I appreciate your way of explaining the extent of the lesion. Good. Because you are explaining according to the landmarks like oral commissure and retromotor. That's very good. Are the nodes significant?
Sir,
Is this the node
nodes.
which we are palpating in the level 1B region? Is it a lymph node?
No, he
Yes,
is
sir.
not agreeing it's a lymph node. Yeah.
So this one, no, sir, it was not mobile, sir. And it's present over the mandible body, sir,
Okay.
inferior border of mandible. So a hard swelling, not mobile, present at the inferior border
So
of the
what do you think
mandible.
it is? It is a bone osteoma?
So, sir, because it's already a primary is present in the gingivobuccal sulcus.
Okay.
So I went with it should be a bone infiltrating into the mandible, sir.
So you are saying that the primary cancer itself has involved the bone and it has expanded the mandible. That is what you are trying to say.
Yes, sir.
It is possible that it is called paramandibular spread, but does it look like the same? Because the lesion you told it is only 1.5 or 2 centimeter. Am I right?
2 into 2 centimeters.
2 centimeter
2 into
lesion
2,
in the right lower GV
yes, sir.
sulcus. That's what you told. But the clinical picture looks like it is a node which may be fixed to the mandible.
Dr. Sai, this may not be, you need to understand there is certain ways that tumor extensions go. All right. So if you have a mucosal lesion, it is going to go so far along the mucosa and submucosa to a certain extent, and in the paramandibular soft tissue, but it rarely ever, unless it actually causes a pathological fracture of the bone, mandible, to see disease extending into the submandibular region directly. Okay, so it's an exception or it's a rarity. I mean, I would say I would not come across something like that unless it's a pathological fracture. On the contrary, what is more common is to have the involvement of the submandibular lymph node. All right, so that is a common thing. So if you consider that as a lymph node, which is what I think it will be, how would you confirm whether it's a lymph node or whether it is a direct extension, though? Is there any method you can say that you are right and I am wrong?
Important question. How will you differentiate whether it is a node or a primary infiltration? What is the test called?
By clinically, sir, clinically.
Yeah,
How clinically? How
By
clinically?
digital palpation, sir.
Okay, what will you palpate?
So I would palpate at the floor of the mouth for the thickening of the inner table, the mandible, and against against the mandibular surface, sir. If it is a submandibular lymph node, then it will be palpated at the floor of the mouth, sir, not against the mandibular surface. It's not palpated as a thickening.
So this swelling can be only because of the lymph node or because of the primary or anything else?
The other content includes the submandibular glands.
Correct.
It can be
So
submandibular.
inflammation because of the involvement of the floor of mouth, if there is an inflammation in the submandibular gland, then also it might become. So you have to be very specific how to exclude one by one. So here you have to exclude the node. Then is there any bony swelling? It is a bony swelling or not by palpating the lower border of mandible, whether it is continuous or it is having some, as sir told, some kind of pathological fracture, or there is irregularity in the bony irregularity. And when you do bimanual palpation from the mouth, both from the mouth and from the neck side, then you can find out whether it is a direct continuation of the tumor through the floor of mouth to the submandibular space, or is it a separate swelling appearing in the submandibular space. So it is very important in such a case, because within whatever time you get, you have to do the differentiation clinically. Definitely, when you go to imaging, these things will be more clear.
apart from these things, you should also mention two other things. You have to measure the trismus by using a vernier caliper from the upper incisor to the lower incisor. In edentulous patient, you will measure it from the upper alveolus to the lower alveolus. Second thing, are there any nodes on the opposite side? That is the contralateral side.
No, sir, there are no lymph nodes
You have to
involved in the
mention that no significant lymph nodes.
Yeah.
Lymph
Because once
nodes
you
will be
say
there.
T4A, then opposite is also important.
Yeah. So, do you think that bone is involved in this patient? You told it's T4A. Why?
So it's because of this lesion, sir. One is this lesion,
So, you are
which
thinking
is
that it is a bone lesion
immobile.
itself.
Yes,
Okay.
sir.
So, there is a
So,
1.5.
doctor, how do you assess, sorry, how do you assess
No,
clinically bone involvement?
So clinically,
You
it's
never gave
by
me any, yeah, in your examination, you did not clearly state that this disease was actually infiltrating the bone, or I missed it.
so it's
What did
through.
you, in your examination, tell me to convince that the bone is involved?
So one is the it's present at the over the body of the mandible on the inferior border, and it's fixed to the mandible, sir. It's not mobile.
So you can see a bony dent while you examine.
So no, so bony dent I cannot appreciate sir on by digital examination.
So I have a small query.
Yeah,
If you
please.
could, if Dr. Sai, if you could tell us if there was any widening of the mandible at any point of time between when you did a bidigital examination, did you find that the mandible was widened at any point of time, at any place?
Ma'am, at the thickening on over the
One
ulcerative
is if you're
growth, I
talking
feel that
about
it is.
periosteal thickening on one side, either side, another is widening of the mandible, which would be direct evidence for involvement of mandibular canal too. What about the sensations on the chin?
Sensations were intact, ma'am.
Did you examine?
Yes, sir, I did examine, sir.
How do you examine
Why,
sensation of chin?
why was this question asked?
Sir, because there is mental nerve which transmits through the mandibular canal in the mandible, sir, which supplies is a sensory supply to the chin. So its infiltration, it's a definitive sign for bone involvement, sir.
What Madam asked was a very vital question, because if you are arguing that there is mandible involvement, at least that will give us a sense of how deep that mandible involvement is. Had you examined this and mentioned, isn't it?
Another little query that I had was you mentioned that the patient is edentulous. So was there any unexplained loss of teeth, or what was the reason for his being edentulous?
I think he said he lost it 3 years ago, much before all
Lost
this
it 3
started.
years ago. Was it unexplained loss of teeth, or did he consciously get the teeth extracted for some reason?
No, ma'am. No intervention was done, ma'am. He gradually
So then that is
lost all
all
his
the
teeth,
more a
ma'am, because
reason you should find out how long ago the growth started. It means how old is he?
he's 45 years old, ma'am.
So at 45 years, he's edentulous. So it means there's been unexplained loss of teeth due to some reason. That's all we've been talking about mandibles. So I thought, let me just talk.
Yes, yes.
What are
Very
the
relevant.
questions related to it? Yeah, please carry on.
So his halitosis and all comes from this disease, is it? I was expecting to see some caries tooth, but it's totally edentulous. But you said there was halitosis. In a
Yes,
2
sir.
into 2 centimeter lesion, there is so much of halitosis, is it?
So halitosis might be due to hygiene.
But when it's edentulous, there's very little in hygiene that we need
Hygiene,
to
yes.
worry, isn't it?
Yes, sir.
Yeah. All right. There's something a little unusual about your case. So, yeah.
One
How do you
positive
go about-
finding is that because he is edentulous, the chances of mandibular involvement is high because it is directly over the mandible actually. So let us see how the imaging comes. Okay.
So, how do you evaluate Dr. Sai?
For the primary of the lesion, I would proceed with CCT next, sir. And for as well as the lymph nodes, we can also go with ultrasound neck. For histological evidence diagnosis, we should go with the wedge biopsy or a punch biopsy of the disease of the ulcerative proliferative growth.
So, is there a ulcerated growth in this patient, or it's an ulceroproliferative lesion?
Ulceroproliferative growth, sir.
In the picture, we are not able to see it properly. You might have seen it better.
Yes, sir, it was present in the right gingivobuccal sulcus, sir, extending anteriorly.
Okay. Okay. So would you do what type of biopsy would you do?
So I would do a wedge biopsy, will be more appropriate, sir. Which
Okay.
will be taken at the edge of the tissue along with some normal mucosa.
Fine. Do you want to do a CT scan?
So CCT, yes, a CCT neck. I will do a CCT neck, sir.
Why do you want to do CT scan for this patient? I agree
So,
with your point. But please tell me the reasons.
so because it tells information about the mandibular involvement as well as the neck lymph nodes, as well as the involvement of the major vessels. As it also gives information whether the tumor is resectable or not.
Okay. More so for your patient, because we have um, different views regarding whether the tumor itself is infiltrating the mandible, or there is a level 1B node which is attaching to the mandible. That is the main reason we want to do a CT scan. Okay. Fine. So
You
biopsy,
should
CT
understand,
scan.
Dr. Sai, where 99 out of 100 times it will be a lymph node. Okay, that basic understanding you should have. Yeah.
So
Do you want to do any
mandibular,
metastatic workup?
So metastatic workup, in my case, I would go with a CCT thorax because only the lung mets will be more common, whereas the distant mets will be rare in these cases.
I didn't get you. What is distant mets and lung mets? I thought it was
So
both the
sorry.
same.
So in lung mets, lung mets are a part of distant mets, but the lung mets will be more common, while the liver as well as the bone mets will be more rare.
Okay, fine. Madam, you wanted to ask something, Dr. Tatni?
so which investigation will show involvement of mandibular canal? You said CT of
Yes,
the neck.
ma'am.
So will CT of the neck be good enough for evaluating the mandibular canal?
For
So
mandibular
mandibular
canal,
cortex is better evaluated on CT, but if you're suspecting mandibular canal involvement, you may need an MRI. I stand corrected, sir.
Well, we don't have to just specifically ask for MRI, because intuitively we will take depending upon the depth of involvement. And at any suspicion, the segment that we are going to be resecting will include the entire alveolar canal. So we are not going to be conserving on that canal by doing an MRI. So, in practice, we wouldn't be so tough on ourselves. And certainly I wouldn't want to be tough on the students. So it's okay, I think.
Dr. Sai, I will give you 3 investigations: an orthopantomogram and CT mandible plane and contrast and an MRI. What would you do for this patient to assess the bone involvement?
sir, I would go with the CT, sir, CCT.
Why not MRI?
Sir, MRI,
What is MRI done for?
so MRI is done more for soft tissue planes, no?
Good, good. CT is for
But
bone. Orthopantomogram, why not?
sir, orthopantogram, because patient is edentulous, there are no any tooth in the tooth sockets.
For a lesion to be
And
seen in an orthopantogram, how much amount of bone erosion should be there?
to get it
It's
30%.
just an X-ray, no?
Yes, sir, it's an X-ray.
So at least 30% of bone erosion should be there to be seen. So early
30%.
bone erosion should be seen better in CT scan.
Okay.
Okay,
Or
fine.
better
What
in
other
clinical examination.
What extra information MRI will give you? Where would you want to do an MRI? This is the bone lesion.
Yes, sir.
Where would you do an MRI in oral cancers?
So in oral cancers, if there is any nerve infiltration and involvement of base of skull or any posterior place lesions such as posterior 1/3 of the tongue or any oropharyngeal lesions, then I would better go with MRI, sir. It tells us.
Doc, this case you said has trismus, all right?
Yes, sir.
And, from your photograph, I don't think it is significant.
Trismus, no trismus.
But let me assume that you are correct in your examination about trismus. And the location of this lesion is 200 centimeter in the gingivobuccal sulcus, which I'm not even able to appreciate in this picture. All right. So which muscle do you think would be the cause for the trismus if it was there?
If it would be this, then it would be a buccinator.
Buccinator will cause
Buccinator
trismus.
involvement, but trismus is less likely if buccinator is there.
No,
So,
you yourself
which
are
muscle?
contradicting your statement. You told muscles of mastications there are 4 only.
Yes, sir. 4 only.
And buccinator is not a muscle of mastication. Are you sure about it?
Yes, sir.
Then don't tell buccinator as the answer for a trismus.
For trismus.
One of the 4 you choose.
In this case, it masseter, sir, because it's inserting on the lateral angle of mandible.
Yeah,
If there is a
because
lump
of the
of
location.
oxygen mouth deploy from the venous above you, pull the oxygen mouth towards you, cover your nose and mouth and breathe normally. Make sure your mouth is secure properly before assisting others. For a guest seated on express seats, the life jacket is kept in the
Interested
center
in
of
listening
the
to the
seat.
class on a
For the
flight.
rest of the aircraft seat, the
Yes.
life jacket is located under your seat. In the unlikely event of a water evacuation, flip the life jacket over your head and secure a strap
Somebody
around
has to
your waist.
mute.
At the exit of the red toggle to inflate your life vest. Should it fail to inflate, don't do the tube. If you are
You have to wait till
evacuating
the
from
flight
the
takes
overwhelming
off.
seat, please inflate your life jacket only after you have stepped onto the wing. Each life jacket has a light which gets activated when the battery comes in contact with water. Please note that the life jacket is to be used or inflated only in case of emergency water landing, after the authorization of the cabin crew, and not to be inflated or tampered with during normal
Somebody's in flight, is
circumstances.
it?
There are 8 emergency exit on this
Hi,
aircraft.
can you
Doors
hear
at the
us?
front, 2 doors at the rear,
Yes, sir.
Sir,
and 1 exit
Oh,
over the
hear us.
wings. They are clearly identified by the exit sign. In case of
the
an
person in
emergency,
flight has to
through such
mute
black
himself.
light will guide you
I
to the
see
nearest
a
exit.
person there.
It's
Thank you very much.
Yeah, thank you.
Done, sir. Sorry for the inconvenience. It's all done.
All right. So, Daksai, where are we? Okay, we are talking about muscles of mastication and the reason for trismus in this particular case of yours. So, you're right. We should be looking at masseter as a point of the reason for the trismus. And I'm also not very much convinced about the leukoplakic patch that you're referring to, because they don't, I mean, I may think it is some hypopigmentation, but not necessarily leukoplakia. But then the benefit of doubt is because you have examined in person, so we need to grant that to you. So just to add a little bit of background for you, if this submandibular swelling was considered to be a lymph node, and then it was infiltrating the bone, and therefore the staging of your nodes will change. So you must remember that. So there are
Yes, sir. Externodal.
yeah, so the whole thing will change. So you must be aware of this, and if you were corrected by the examiner, you must change and review the staging of your case. All right. That is the reason why.
If let us say this is a lymph node, then how do you explain the present finding with a lymph node? Just explain. Is it possible for
Sir,
a lymph node? Because sir is telling it repeatedly, because this is the commonest finding. Bony
yes,
swelling presenting is very rare. So if it is lymph node, how will you explain in this patient?
so in this patient, the lymph node will be a round structure, round, non-tender, and will be hard mass because if it will be a lymph node mets, and it's present in the just submandibular triangle. So those are the findings that help that tell
So
that
is
it
it
might be.
possible that a present structure can be a lymph node?
Yes,
in this
it can
patient?
be a lymph node with extranodal infiltration into the mandible.
Exactly. That is what. And with extranodal extension, where does it infiltrate?
External in the surrounding structures, lymphovascular
What is the
structures.
surrounding structure? What is the surrounding structure?
So one in this case is a facial
No,
artery
the
and
bone itself, mandible. So how does it look like a bony swelling, even if it is a lymph node? Because the lymph node is hard, there is extra nodal spread, and it gets fixed to the periosteum. So then it will just mimic like it is a bony swelling. So that is what is in this case. Let us see about the imaging findings, but we are quite sure that is a fixed lymph node with external spread and periosteal involvement. It has got fixed to the mandible.
Okay, doctor. What is the biopsy report?
So biopsy is a well-differentiated squamous cell carcinoma. Sir.
Okay. Can you show us the CT scan findings?
Yes, sir. So these are the CT scan findings, sir. It shows a ill-defining enhancing soft tissue thickening
No,
and
no.
seen
We
in
want the
involvement.
images, please.
So these are the images. Here we can see the thickening, sir, in the right gingivobuccal sulcus, and
Now you tell us findings in the CT scan.
so there is an ill-defined thickening in the right gingivobuccal sulcus, sir.
Correct.
Right, and there are also lymph nodes involving the right submandibular region, sir. This is largest lymph node of 3 into 2 centimeters, sir. Also.
Okay.
And
So
sir,
now what do you say?
so so I would say this is the primary thickening, and this will be the lymph node, sir.
So there is no bone erosion or bone
It
is
was
not expanded.
bone is not expanded, sir, but in the report there was given that bone is eroded.
No,
But you
don't
have to
go
see
by those
don't see the
findings.
report.
Your clinical findings are more important than the person who has reported.
Yes,
That is
sir.
why I told you that once sir is repeatedly trying to tell you that you have to change, still you were arguing. But you see now, the mandible on the right side and the left side, as Dr. Ratna was pointing out, even there is no expansion of or widening of the mandible. It is of the same caliber. And you can see that rounded lymph node just adjacent to the mandible. And even in the coronal section, you can see just below the lower margin of the mandible, you can see the rounded structure. So it is nothing but a lymph node. And as I told you, there is extranodal extension and it is getting fixed to the periosteum. That is why it is confusing that it is from the bone.
Okay.
Good.
Yes, sir.
Okay, so we'll stand corrected, Sai. Okay, let's say that it is a lymph node with perinodal disease. Never mind.
Yes.
So your chest thorax is all fine. Okay, so what do you want to do next? I think we'll run short of time otherwise.
Yeah.
Sir, I would stage after metastatic workup. I will stage the disease, sir. As the the T stage will be, sir, T2 is a 2 into 2 centimeter lesion. I would go with a T2, sir. And as the extranodal extension is present, I would go with N stage will be N3B and M0, sir.
Good.
So it will be a
Very good.
stage 2, stage 4B, sir. Stage 4B. It will be locally advanced carcinoma, but for this is squamous cell carcinoma of oral cavity. Surgical resection is the definitive treatment, and following wide local excision with modified radical neck dissection and segmental mandibulectomy with flap reconstruction. In post-operatively, I would go for adjuvant radiotherapy.
So
The
this is a
radiation or some more?
Radiotherapy,
More.
so with systemic systemic chemotherapy also.
So it's,
this
you
is
can
a
add
early
chemo
cancer or
radiation.
locally advanced cancer.
So locally advanced cancers.
So what is the
4B
philosophy
will-
of treatment of early cancer and philosophy of treatment of locally advanced oral cancer?
So in early cancers, we can directly proceed with surgery, sir. But in case of locally advanced, we can downstage the disease by using systemic chemotherapy.
So what I'm trying to ask you is single modality in early cancers and multiple modality in locally advanced cancers. So
Locally
this is a
advanced.
locally advanced cancer. You are correct that you want to do a surgery as first. So what type of surgery will you do?
So I will do a wide local resection of the lesion with 1 centimeter margin, as well as segmental mandibulectomy with modified radical neck dissection on the ipsilateral side. with flap reconstruction of the tumor site, so resected site.
Now,
What
tell me
modification
what.
would you do? In the neck dissection, what modification would you like to do? And we're going to close in 5 minutes. That's the instruction we have. So
Sir,
2 questions for you to wrap up from my side. What is the modification and neck dissection you are contemplating? And number 2 is whether are you treating this with an intent to cure or are you treating this with an intent to palliate?
firstly, sir, the modification in the neck dissection include resecting all the levels of lymph node 1 to 5 with try to preserve the spinal accessory nerve, the sternocleidomastoid muscle, as well as the internal jugular vein. And sir, in this case, the intent was to cure, sir, initially resect all the tumor diseases, both at the primary site as well as the nodal neck nodes, neck disease.
So would you
Good.
do a segmental mandibulectomy or a marginal mandibulectomy? Whatever you do, tell me the reasons.
Sir, for marginal mandibulectomy, the mandible should
In
not
this
be
patient,
involved in the clinic. In
stick to
this
this
patient,
patient.
sir, I would go with segmental mandibulectomy, sir, because
Why?
because
Answer is correct,
in the
but just
report it
explain.
was so one clinically, so as they discussed the lymph node, there is extranodal spread involving the mandible, and radiologically also there was a erosion. It was given in the report that there was erosion into the mandible. So clinical and radiological involvement of mandible requires mandibulectomy.
But one more point is it is edentulous. The height of the mandible will be only 1.5 centimeter. You cannot do it. It's a contraindication for a marginal mandibulectomy. An
Exactly.
extranodal extension, as you pointed out, is very good.
If he's edentalous all his life at 45, why don't we just resect the hemimandible and put a PMMC?
Sir, because hemimandibulectomy is it causes a deformity in half of the lower face, and flap.
Worried about deformity or you worried about function? The
So
patient is
function
not
also,
worried
there
about
will
the
be
function. But he's
function
not worried about the
post-operatively.
function.
Swallowing and speech will not be efficient in this patient.
You're deviating. Okay,
So
we'll wrap
if
there.
you do
Okay,
a
you've done a good job.
segmental resection, then how will you reconstruct? What is your plan for reconstruction?
So the reconstruction by bone, either artificially, so now we have available titanium plates and screws, or patient autograft by the
Are
bone
they
from the
advisable
fibula.
in such a case?
So actually, they have many complications of post-operatively, such as surrounding erosions and descents of the flap itself.
No, extrusion of the plate. That is the commonest in all these cases. So when you are going for a segmental resection, then the chances of putting a plate and then going for extrusion, the only answer is to do a free fibula. Free fibula will be very costly for such a case, and I don't think this patient will be able to afford a free flap unless it is a medical college and where the plastic surgery department want to do the microvascular free of charge. Otherwise, all of us in at least in private, we will prefer to put a PMMC and get away with a low cost and keep the money for the radiation rather than going for a free fibula and make the things more complicated for future. So I think what Sar was pointing, putting a PMMC is much better, and even it can be done if you do a wider segmentectomy. But if you do a hemimandibulectomy, then it allows the whole PMMC to get adjusted, and the cosmesis is not bad actually, if you think.
Sai, you did a good job. Thank you.
Yeah. Only point was you should have not believed the report of the CT scan rather than your clinical findings. That is because the surgeon's hand is the most important. Rest are all additional findings. They don't contribute to the primary primary, exactly the primary case. The surgeon's findings are more important. So you should have told that this is a node getting fixed to the bone, rather than accepting that they had written some kind of erosion. Very commonly, if they see any small adjacent to the gland, any small rarefication in such a old age in edentulous, it is very difficult to report. So they might have written, but it has got no meaning with the primary findings.
I have a query, a small query again. Is it how much improvement do we expect in mouth opening, and which component of the surgery would affect the mouth opening?
Ma'am, during surgery, we need for tumor approach of the tumor, we have to do a split mandibulotomy is required, ma'am, due to the trismus.
No, in this surgery that we have done, will the mouth opening improve?
Ma'am, mouth opening.
Which component of your surgery would affect mouth opening? It's a genuine question. Maybe the other faculty can answer.
So what ma'am is asking, that what component of your surgery? So what are the components of your surgery?
So one, the primary resection of the wide local excision of the
Correct.
tumor.
Number
the
two,
segmental mandibulectomy, then the
number
modified
three
radical
is the
neck
nodal
dissection.
dissection. So
Yes, sir.
the answer is very simple. You are telling yourself what will improve your mouth opening.
So the segmental mandibulectomy.
The bony resection, very simple. Because
Segmental
primary
section of mandible improve mouth opening. It's just a segmental. It has got nothing to do with mouth opening. No, the segmental resection of mandible in that area. So probably I missed out on the extent of the tumor that you described. So was it involving any part of the muscle, or I mean, would your wide local excision?
We are even not convinced about the trismus actually, because the person is quite widely opening the mouth actually.
Yeah. Because looking at the extent of tumor that you've described,
it's very small actually, very small.
And none of these would affect mouth opening.
Yeah.
Thank you, Dr. Sai. You can go on to the next case.
Thank you, sir.
Good job. Thank you very much.
Thank you, sir.
Sir, you want to clarify any doubt from faculty?
No, sir.
Okay. Thank you.
Dr. Sai, do you have any doubts to be clarified?
Sir, no, sir.
Thank you very much. Good luck. Thank you, Rahul, sir.
Thank you, sir.
Dr. Monisha, are you here?
Yes, sir.
Yeah. Amit sir has joined, ma? Professor Amit sir has joined now?
Sir, no, sir, not it, sir.
Okay, no problem, no problem. Please introduce yourself, your unit chief, and start your presentation. Have any challenges in sharing the PowerPoint?
Yes, sir, I'm trying, sir. Sir, I couldn't share, sir.
What is happening, ma? You do the same thing how you did it for the first time when you did the trial. Yes, you're good to go. Now you make the screen smaller. Open the PowerPoint. Minimize.
Sir, Sir.
No, Kana, what you do is you please unshare this. Yes.
Yes, sir.
What you do is now you, except Zoom, you close down all the windows. You have whatever
Sir,
subsidiary windows you have opened, please leave it closed.
sir, even PowerPoint, sir, or do I have to leave the PowerPoint open?
PowerPoint, including PowerPoint.
Yes, sir. Closed, sir.
Okay, right. So now you press the share screen option. What are the options you are getting?
Sir, Microsoft Edge tab, sir.
Hmm.
Window.
Full screen you are getting, entire screen or entire desktop.
Yes.
Okay, press that.
Yes, sir.
Yes. Now you minimize this.
Yes, sir.
Now open the PowerPoint.
Sir, is it visible now, sir?
No. Okay, don't worry. You open the Zoom again. Maximize the Zoom. Yeah. Now you unshare
Yes,
for a
sir.
moment. Just unshare this. You have PowerPoint is
Yes,
open,
sir.
right? Yeah. Press the
Yes, sir.
share option now. What are you getting?
Sir, window I am getting, sir.
You are getting the PowerPoint screen? Yes. Good. Now
Yes,
make
sir.
it full screen. You are good to go. Good luck.
Yes, sir. Thank you, sir. Good evening, everyone. Myself, Dr. Monisha, third year junior
Kana, you
Department
make
of
it to
Surgery,
slideshow mode, ma?
Mr. Chikesh. Yes, sir, I have done, sir.
For some reason, we are not able to see the slideshow mode. But don't worry. It's already getting delayed. Please go ahead.
Yes, sir. My moderator and my thesis guide is Professor Amit Gupta, sir, Department of Surgery, in charge Department of Surgical Oncology from AIIMS Rishikesh. Mrs. X, a lady aged 55 years, who is a resident of Rishikesh, Uttarakhand, who is a hospital attendant by occupation, presented with chief complaint of pain in right upper abdomen for 6 months. History of presenting illness. The patient was apparently asymptomatic 6 months ago, after which she developed pain in right upper abdomen, which was insidious in onset, dull aching type, intermittent in nature, non-radiating, no aggravating factors, and related by oral medications, which has become continuous pain for the past 20 days, increased in severity, related by injectable medications, and not associated with fever. History of reduced appetite for 20 days.
Can you
History
move
of
to the next slide?
Sir, I'm moving, sir.
But we are not able to see anything. Others are able to see it.
No, sir, no.
I think she has to make it slide
Slideshow.
view, then only it
Slideshow.
will move. Otherwise, you have to click the slides to go to next.
Sir, is it visible now, sir?
I
Yes.
think in the
Yes.
lowest part,
So may I proceed, sir?
Please.
Yes, sir. History of undocumented unintentional weight loss present in the form of loosening of clothes. No history of yellowish discoloration of eyes, skin, or urine. No history of vomiting. No history of passage of black tarry stools, bleeding per rectum or hematemesis. No history of hematuria. No history of abdominal distension. No history of headache, seizures, shortness of breath, cough.
Monisha,
Yes,
again,
sir.
slide is not moving. Okay.
Sir, is it visible now, sir?
Yeah.
Yes. No history of abdominal distension, no history of headache, seizure, shortness of breath, cough, hemoptysis, back pain, or bone pain. Uh, Past medical and surgical history. The patient was diagnosed to have gallstone disease 2 years ago. On evaluation for vague abdominal pain with an ultrasound. After that, patient was not receiving any treatment for the same, since she had symptomatic relief after that. No known comorbidities, no history of surgery in the past, no known allergic history for the patient. Personal history. Patient is a vegetarian diet consumer. No history of any substance abuse. Sleep of the patient is disturbed due to abdominal pain. Normal bowel and bladder habits for the patient. Menstrual and obstetric history. She attained menopause 10 years ago. Obstetric score is para 1 live 1. Delivered via normal vaginal delivery. No history of hormonal replacement therapy used in the patient. Family history. No history of any malignancy or malignancy related death in the family. Summary. A lady aged 55 years, resident of Rishikesh, Uttarakhand, presented with pain in right upper abdomen for 6 months, with a recent change in nature of pain and reduced appetite for 20 days, history of unintentional loss of weight, no history of fever or jaundice, history of gallstone disease diagnosed for 2 years, and no known comorbidities.
What is your conclusion by your history?
Sir, my provisional diagnosis would be gallbladder malignancy, sir.
Why?
Why would you think?
Yes, sir. So the gender of the female, gender of the patient female, and fifth decade, patient is a resident of patient belongs to North India, sir, and the patient has a history of gallstone disease, which was diagnosed 2 years ago. The patient was having biliary colic initially, which has recently changed to continuous severe pain uh, and associated loss of appetite and loss of weight. Uh, this history pointing towards gallbladder malignancy, sir.
Could be any malignancy, dog. This need not be necessarily gallbladder. Why you go specifically to gallbladder? Huh? Unless you're so biased. See, upper abdominal pain of
Yes,
no
sir.
specific character pointing to a gallbladder origin, and you see there is unintentional weight loss and
Yes, sir.
loss of appetite. There is no pointer to say that this is due to gallbladder. Gallbladder may be a differential diagnosis,
Yes,
but there could be so many other things that can happen. What are the other things that can happen?
sir. Patient might have xanthogranulomatosis cholecystitis also, sir, or it could be empyema gallbladder.
Why
But
you're only
So you
centered
have
on
mentioned.
gallbladder?
sir, since there is a history of gallstone disease, sir, more likely, sir. Other things could be the
Monisha,
patient may be having.
I'm going to argue this patient is having a carcinoma of the stomach. What are the points against carcinoma of the stomach?
Uh, Sir, the patient will be having some symptoms present to GI bleed could be there, sir.
Why should it present a GI bleed? What percentage of cases present a GI bleed in carcinoma stomach? It's very rare. Okay.
Yes, sir. The patient.
What are the common symptoms of carcinoma of the stomach?
Sir, postprandial fullness, discomfort. The patient can have vomiting, sir, if the patient is presenting in gastric obstruction, sir.
What are the parts of the stomach?
Sir, cardia, fundus, body, antrum, pylorus, sir.
So only if it is there in the pylorus antrum region, you are expecting obstruction. But you
Yes,
could
sir.
have malignancy in the rest of the stomach as well, isn't it?
Yes, sir.
And would it not cause exactly the same set of symptoms?
Yes, sir.
So why would you not think of stomach? Is it because you think in the region where this patient is hailing from, the gallbladder malignancy is so common when compared to the carcinoma stomach? Is that the reason?
Yes, sir. That's the reason. That's why I kept it first, sir. Other differential diagnosis could also be present, sir. Like
I'm
you
Madam, you
said,
saying
have
this is
mentioned.
due to carcinoma of the ovary, though. It's a carcinoma of the ovary. Do you like to disagree with me?
sir.
She's a lady.
Yes, sir.
So you have ovary, you can have deposits in the subcostal region. You can
Yes, sir.
have dull aching pain there. So, you should not be so dogmatic at this stage of your history taking,
Yes, sir.
but keep things open. Okay.
Yes, sir.
So one thing is we are looking at least with the reference to the loss of weight,
Yes, sir.
something of a malignant nature. That much we can say.
Yes, sir.
Some malignant problem is happening,
Yes, sir.
probably in the upper abdomen. And the
Yes,
upper abdomen contains so many things: the liver, the stomach, the gallbladder, pancreas, everything is upper abdomen. And so therefore, we have to now try and find out what are the other clinical findings which will fit into one or the other.
Yes, sir.
Based on these symptoms only, we cannot conclude that it is gallbladder. And if you said it is gallbladder, we will consider that you are very biased towards a diagnosis.
Yes.
Monisha,
Yes, sir.
Monisha, as you mentioned that there is a pain in the right upper abdomen and
Yes.
recent change in the nature of pain.
Yes, sir.
So whether gallbladder malignancy will present as a pain?
Yes, sir. In advanced cases of malignancy, the patient can have pain, sir.
And previously also there is history of pain from 6 months.
Yes, sir. Sir, according to her description, it was more towards biliary colic, sir. Now it has become continuous severe pain, sir, for the past 20
You
days.
said there is a colicky pain, history of colicky pain, which has now changed in character. Is that how you present it?
Sir, as she mentioned, it was
Let's,
dulling intermittent episodic pain, sir.
so let's even argue what are the parts of the gallbladder and how will it present with the colicky pain?
Sir, parts of the gallbladder would be fundus, body, and infundibulum, neck.
Right. So which part will give rise to colicky pain?
Sir, if gallstone is present in the neck, obstructing the neck or cystic duct, sir.
All right. So in that case, with such an advanced disease causing loss of weight and change in nature of pain, would you not think that the disease would extend to
Yes.
the main bile duct?
Yes, sir.
And therefore, what should it cause?
Sorry, sir.
The manifestation should have been jaundice in other way.
Yes, sir.
So we are not seeing jaundice in this patient as a main complaint.
Uh,
So therefore, we are seeing, if at all it's gallbladder, it's away from the infundibulum.
Yes, sir.
And therefore, your colicky pain is not tenable at all.
Yes. Sir, can stones cause biliary colic pain, sir, and which is a risk factor for gallbladder malignancy, and the malignancy has occurred, sir? Like, could it be a
Can
possibility?
be,
Yes, sir.
can be. Did the stone cause jaundice anytime? Did it
No,
cause
sir. No, sir.
pancreatitis anytime?
No, sir.
So why would we think of stone in the draining
Pathway.
passage? Isn't it?
Yes.
Okay.
Yes.
Yeah. So we need to justify the symptoms with what we are trying to see. Okay. So let's keep an
Yes.
open mind about all
Yes.
these anatomical structures and go
Yes.
about physical examination. Okay. What's your physical examination? Summarize your physical examination.
So
Just
can I move
the
to the slide?
local exam. Yeah. Move the slide and only give us the summary of your positive findings. We don't want all this.
Yes, sir.
There's a summary of your physical examination findings.
Sir, on examination, there was a irregular lump, sir, of size around 20 cross 15 centimeter, palpated in the right hypochondrium, extending into epigastrium and umbilical region, whose all margins were palpable except superior margin, sir. And it was moving with respiration, hard in consistency, and side-to-side mobility was restricted, sir. And there was a palpable hepatomegaly present, sir. And no free fluid was there, sir, and left clavicle lymph node was not palpable.
Excellent. So now what would you consider the anatomical origin?
Sir, it is pointing towards malignant gallbladder lumps, sir.
Why not a liver mass?
Yes, sir. Exophytic growth from liver could also be a possibility, sir. But
You still
but medial and
like
lateral and the inferior borders of the swelling are well palpable, sir. Except the upper margin, which is continuous with the liver dullness, which is liver, sir.
so now you think it can be only gallbladder or it can be liver as well?
Sir, first probability I will keep as gallbladder lump, sir, and second thing could be some exophytic growth from the liver, sir.
So
Can it
why is
be
it not?
pheochromocytoma or adrenal tumor?
Yes, sir. But this swelling is moving with respiration, sir.
Okay. So what are the structures in that area think of anything. Can it be from the hepatic flexor colon growth,
Yes.
exophatic?
Yes, sir. But swelling of this much size, we can expect
So
some.
you have to individualize that if this is happening, this is there, this is there.
Yes.
Then you, according to that, you from the examination only you can exclude the DDs.
Yes, sir. Sir, if it could be hepatic flexure growth, sir. First, a history the patient might have some bleeding PR or some melena, sir. We can expect that, sir. And in examination, the upper border of the swelling also should mass also should be palpable, sir. Since the upper border of
Correct.
the swelling is not palpable here,
Not
then
necessarily. In a
yes, sir.
hepatic flexure, you can have infiltration of the liver and blend with the liver. So not
Yes, sir.
necessary that you should fill the upper border.
Yes, sir.
Yeah. But you're right, there must be some lower GI symptoms associated.
Yes, sir.
And in a hepatic flexure, you cannot expect that silent growth like you can get it in the cecum or the
Correct.
ascending colon. So therefore, we can't argue saying that there is no symptom because of that. Okay, so we grant you that. But when you say it is gallbladder and you're very strongly feeling towards it, and the patient is presenting with this changed character of pain with the unintentional loss of weight,
Yes.
what other examination would suggest that this is an incurable disease?
Sir, metastatic, incurable, sir, metastatic symptoms, sir.
Clinical examination,
Yes, sir.
what are the features you will look
Sir,
out
on
for
inspection,
considering this as incurable?
yes, sir. So on inspection, the patient might have umbilical
Don't
nodules.
just tell me these points are going
Yes,
to
sir.
make it incurable.
Yes,
Which
sir.
one? No
Sir, left
inspection.
supraclavicular lymphadenopathy, sir.
Very
Left
good. Did
axillary
you look for
lymphadenopathy.
it?
Yes, sir.
Did you look for? Yeah. So
Yes,
there
sir.
is no lymph node there. Okay.
Yes.
Axillary node was not
Axillary
there.
lymph nodes, sir. And
Okay. Then
Sister Mary Joseph nodules, sir. And free fluid, sir. Ascites, or Blummer shell deposits, sir.
did you look for the deposits there?
Yes, sir.
What examination did you do?
So parental examinations.
Not pervaginal.
So the patient did not give consent, sir.
So you did the pelvic examination to rule out this. So you ruled out all this.
Yes, sir.
All right. So you think this is a curable, treatable disease?
Sir, according to the thing, sir, but so gallbladder malignancy presenting with this much lump, if the diagnosis is gallbladder malignancy, then this much lump, then we have to do imaging, sir, because it might be
That's
local
fine. But
advanced.
clinically, you feel this is worth imaging.
Yes, sir, no signs of metastasis, unresectability.
Correct. That's what you should say. Okay.
Yes.
So clinically, you cannot exclude the possibility of cure.
Yes.
Although intuitively you understand such a big mass generally is not resectable, isn't it?
Yes.
Okay, go ahead.
Sir, we did ultrasonography of whole abdomen for the patient, sir.
Okay.
Sir, it showed gallbladder was irregularly thickened with contiguous involvement of adjacent liver parenchyma. There was a likely gallstone was there, sir. And multiple non-contiguous hypoechoic lesions are seen in the right lobe of liver, and liver was enlarged. No IHPRD was seen. The impression, peripancreatic enlarged lymphadenopathy was there. Impression was neoplastic gallbladder lesion with likely liver metastasis, sir.
With likely liver metastasis?
Yes, sir. So there were multiple non-contiguous hypoechoic lesions in the right liver present, sir.
In which lobe
So right lobe of liver, sir.
or which segment? You know what are the lobes of liver and what are the segments?
Yes, sir.
What are the lobes?
So right lobe, left lobe, sir.
What are
How
the
they are
segments?
divided?
Sir, Cantley's lines.
Okay. Then what are the segments?
Sir, 8 segments are there, sir.
Okay.
Sir, left lobe consists of 1, 2, 4A, 4B, sir. And right lobe comprises of 5, 6, 7, 8, sir. Along with caudate
Good.
lobe. In the,
Good. So in the ultrasound, there are multiple hypoechoic lesions. So
yes,
this is CA gallbladder with secondaries,
yes, sir. Likely, sir.
likely. Okay, continue.
So routine blood investigations were done, sir. The abnormal investigations were raised enzymes, sir, with 90 and 100, sir, and ALP, GGT were raised, sir, in 800 and 900, sir.
What
CEA,
are the CA 19.9? Oh, okay, please.
sir, CEA was 340, sir. CA 99 was kit was not available at the time in AIMS, sir, so it was not done, sir.
So what will be the CA 19.9 usually in these type of cases?
So it will be raised, sir.
How much rise?
Sir, we can expect in more than 100 to 100.
It will be in thousands in
Yes,
a
sir.
metastatic disease. Okay,
Yes.
So I have
continue.
a question.
Yes, ma'am.
Dr. Monisha, if there are non-contiguous metastases in, say, segment 5 of the liver, would you consider that to be as distant metastasis, or will that be considered as regional metastasis?
Ma'am, it is not considered as distant metastasis, ma'am. It will
Yeah,
be regional, ma'am.
yeah.
We can go for a
When you
segmental resection.
when you consider multiple, that is why Dr. Acharya was probably asking you about the segments of liver.
Yes, ma'am,
Because
but it was not.
metastasis in the right lobe, you should be able to specify by looking at imaging that which part.
4B and 5. You
Five.
should be very specific. 4B and 5.
Yes, yes. Sorry, sir, it was not mentioned, sir, in the report.
Continue.
Yes, sir. Sir, CCT thorax, abdomen, pelvis was done, sir. In thorax, there were multiple heterogeneously enhancing soft tissue nodules were there, sir, likely metastasis. And there was pulmonary thromboembolism noted in the right pulmonary arteries, sir. And abdomen, asymptomatic heterogeneously enhancing mass lesion of size 10 cross 10 cross 10, 8 centimeter with internal necrotic areas involving gallbladder fossa with focal wall infiltration into the adjacent segments 4A, 4B, and 5. Multiple well-defined variable-sized peripheral enhancing hypodense lesion are seen in both lobes of the liver. Largest was 3 cross 2.8 centimeter. It is liver metastasis. And the lesion was enhancing the right hepatic artery and portal vein, main portal vein. There were periportal, peripancreatic, and retroportal lymphadenopathy was there. The lesion was abetting pancreatic head, duodenum, antropyloric, and hepatic flexure. IHBID was noted. Primary confluence and right secondary confluence, CHT, CPD was involved. There was splenic infarct noted in the upper pole of the spleen. So this is a video of CCT, sir.
Yeah, you can describe.
Yes, sir. Sir, there were multiple peripheral enhancing lesions, sir, hypodense lesions, sir, are seen in the liver in right lobe.
So what are the phases of this contract annest CCT abdomen?
Sir, arterial
Are
phase, sir.
there any phases?
Yes, sir.
What is it exactly called?
Sir, triple phase, sir.
Correct.
Arterial,
So what are the phases?
sir, arterial phase, sir.
Hmm.
Portal venous phase and delayed phase.
And
Yes,
parenchymal. Parenchymal. Okay.
Yes, sir. Yes, sir.
Yeah. You can describe the findings.
Yes, sir. Sir, asymptomatic irregular heterogeneous enhancing lesions, sir, noted in the GB fossa regions are here, which is infiltrating into the liver. Sir, and nodes, peripancreatic and periportal lymphadenopathy also we can see, sir.
And multiple hypoechoic
Yes, sir, lesions.
lesions.
So splenic infarct
Okay.
is also, yes, sir.
And what else you will see in this? Let us say it is this case is inoperable. In
Yes,
an
sir.
operable case, what else you will see?
Sir, initially the lesion, sir, thickening or any mass, the local infiltration, sir, liver infiltration, liver invasion, or any extra hepatic bile duct invasion, other surrounding structure invasion, sir, and any vascular invasion present, lymph nodes, then ascites, sir, and any distant metastasis, sir.
So you should always see anatomy, then the pathology.
Yes, sir.
Okay.
Yes, sir.
So in anatomy, what are the anatomy you are going to see?
Sir, the
Only the
original
biliary anatomy, anything else?
vascular anatomy, sir.
Yes. So in vascular anatomy, You have to see whether there is infiltration to the commonest to the
Portal vein, right hepatic artery, sir.
correct. So right hepatic artery and portal vein. So vascular anatomy is important. Then
Yes.
you will come to the pathology, SITs and whatever you told. These are important. Then
Yes.
finally, when you are seeing the hypoechoic areas, then you
Yes,
have to see what you will see. How will you know they are malignant and how they are different from the primary tumors of the liver? How will you know? What is it is called?
sir. Target lesion, sir. There will be peripheral enhancement and it will hypo.
Actually, there will be a washout.
Yes, sir.
Okay, target washout. So
Yes, sir.
if it happens, then it is more chances of having SCC. Okay.
Primary.
So in this only you will find hypoechoic with a peripheral contrast enhancement.
Yes, sir.
Correct.
Yes,
So
sir.
you should know little about the CT scan methodology and what are the things, and then the nodes. So anatomy, pathology or the disease, and the nodes, and the characterization of the pathology. All this is done with the CT scan.
Yes.
So, Dr. Manisha,
Yes,
if the
ma'am.
report said that there was atrophy hypertrophy complex with the atrophy of left lobe, how would you interpret that?
Ma'am, probably portal vein infiltration, ma'am. Luminal narrowing.
Probably the left pedicle is involved, so you have to keep
Yes,
that in mind.
Correct.
Yes, ma'am.
Dr. Monisha, you told about there is a pulmonary thromboembolism for this patient. Am I right?
Yes, sir.
Is the patient symptomatic?
No, sir. Not symptomatic, sir.
But it was involving the main pulmonary artery, if I'm right.
Sir, right pulmonary.
Okay.
So bifurcation of right pulmonary arteries.
So, what are the thrombi that you expect in this case?
Ma'am. Sorry, ma'am. Thrombi.
So, what kind of thrombi can be expected?
What are the two types of thrombus?
Sir, atherosclerosis, thrombus, and
One is because of the tumor compression and stasis, there can be a blood thrombus that happens.
or a
Another
hyper.
is a tumor thrombus. How do you differentiate between the two? The tumor thrombus will not be stuck to the vessel wall. Yeah.
What is the most common site of thrombus in such a case?
So DVT, sir. Deep veins in lower limbs.
No. In relation to this patient, in relation to the liver.
Portal vein is a portal vein thrombus or.
Correct. So that is what madam was asking.
Yes, sir.
So what are the cancers which can cause thrombus formation? Tell me three cancers which can cause thrombus.
So pancreatic cancer, sir.
Okay.
So gastric cancer, sir.
No. Thrombus in relation to the adjacent veins. I'm not talking about DVT, deep venous thrombosis. I'm asking, for example, hepatocellular carcinoma
Yes,
can
sir.
cause thrombus into the
Yes, sir.
IVC or portal vein. Fine.
Yes, sir. So renal cell carcinoma, sir.
Good.
Good.
Into the renal vein and to the IVC.
IVC.
One more. Follicular thyroid cancers can move to
Yes.
the internal jugular vein. So these are the common key cancers where metastasis can occur through thrombus formation.
Yes, sir.
Yeah, fine. Now, you have done a biopsy? Is it
Yes,
needed?
sir. Yes, sir.
Is it needed in this case?
Yes, sir. So to
Why?
prove, so to prove the tissue diagnosis, sir, and for further palliative treatment, sir.
Okay.
Good. Did you do a biopsy?
So biopsy has been done, sir. Report is awaited, sir.
How did you do a biopsy?
Sir, ultrasound guided percutaneous biopsy from gallbladder and liver lesion, sir.
So what is the performance status of this patient?
Sir, performance is good, sir. ECOG 1, sir. So
I'm
patient
just
was,
surprised because with all these findings, the performance status is PS1. It can happen. It is very rare.
yes, sir.
Yeah, because you are already telling there is thromboembolism.
There
Yes,
is
sir.
multiple lung mets. There is thrombus. There
Yes,
is
sir.
large liver mets.
Yes,
Yeah.
sir.
Yeah, fine. Good. The biopsy, let us assume that it is a gallbladder cancer. Okay.
Yes, sir.
So what biopsy can you expect? What can you expect in the biopsy report?
Sir, adenocarcinoma, sir.
Okay, fine,
Common.
good. So what is the course of further management? It's the intent of treatment for this patient.
So palliative intent, sir.
Good. So if it is palliative, then how do you proceed further? Just tell us.
You
Sir,
told there is alteration of the liver function test, I think.
yes, sir.
What was that? OTPT was high.
Sir, yes, sir. 90 and 100, sir. And ALP, GGT were raised, sir. 800 and 900 respectively.
How do you explain that?
Sir, because of the infiltration of the tumor into the liver and multiple liver metastasis, sir, that has caused ALP and GGT raised, sir. Probably the
So
patient
it is
will
a obstructive cause or
Obst-
it is a hepatic cause?
Sir, both we can expect, sir. Hepatocellular damage and obstructive cause we can expect, sir.
Both can happen here.
Yes, sir.
So if it becomes obstructive, then how does it how the patient presents?
Sir, with jaundice and itching, sir. Platelet stones.
Yeah. So CA gallbladder with a jaundice is a very common finding.
Yes,
And
sir.
if you have jaundice, then what is the why does it happen?
Sir, it could be due to direct infiltration of the tumor into the CBD, sir, or it could be the compression, or portal lymphadenopathy can cause CBD, CHT, CBD compressions are causing jaundice, or multiple liver metastasis, or caudate lobe liver metastasis, sir, or concomitant cholelithiasis cyst can be there, sir. Dual malignancy, cholangiocarcinoma can be there, sir.
Good. So once it is there, then you have to see the biliary anatomy to what extent of the biliary tract it is involved, whether it is primary confluence is involved or going to secondary confluence. According to that, you have to do the palliation. So what is your intention of palliation and what will you do in the palliation?
Sir, currently the patient is having a pain, sir. So palliation of pain will be done, sir. If the patient develops jaundice and dural outlet obstruction in the due course of time, then that will be palliated accordingly, sir. Now the patient pain will be palliated, sir, and palliative chemotherapy will be given, sir.
How do you palliate the jaundice?
So for jaundice, percutaneous transhepatic biliary drainage can be done, sir, or ERCP where stenting can be done, sir. Metallic stenting can be done, sir.
Does ERCP stenting work in this such type of case?
No, sir. Since it is advanced case,
When it will work and when it will not work?
sir, in advanced cases, if the patient is having dural infiltration, then it is not feasible, sir.
And sometimes there is only infiltration of the right duct. Then you can put a stent on the left side. But if both the ducts are involved and secondary confluence are involved, there is no chance except that you have to have a PTBD only, and you
Yes,
might have to drain multiple ducts depending on the site of obstruction, because one duct just draining with PTBD may not help the patient to be having the palliation. So these are very difficult kind of scenarios, but
yes,
once the patient presents, you have to do all this to make whatever prolongation of life that is possible.
yes, sir.
Anybody want to ask more?
What is segment 3 bypass and when is it indicated? Or is it indicated at all?
Yes, ma'am. Ma'am, if the conference is intact, then we can go for segment 3 bypass, ma'am.
So if you expect that the survival is likely to be more than 6 months and you want to palliate jaundice, then you may consider a surgical What is rendezvous technique of stenting?
Ma'am, rendezvous, ma'am.
Yeah.
Ma'am, it is both from upper and below, ma'am.
Yeah, very
Usually,
good.
it
Because you
means
prefer internal stenting. So instead of just PTBT with an external stent, you may try negotiating from both the sides. And
yes,
yeah.
ma'am.
Yes. What is an access loop?
Ma'am, while constructing a hepaticojejunostomy, ma'am, the dependent loop we can take through percutaneously and
You
we
leave
can
it in the, excellent. You leave it in the subcutaneous plane for if you expect
which
another
we can use
access.
for yes, ma'am, future any dilatation needed or any access we can use that, ma'am.
What are the other recent advances in managing metastasis in the liver?
Ma'am, immunotherapy, ma'am, we can go
Yeah.
for.
So now
We
we're
can
talking about multiple metastases in liver. If you come across such a patient, what are the various techniques that are available? Immunotherapy, you may give BCG injections. Very rarely practiced. What are the other means? So
ma'am,
radiofrequency
ablation.
ablation and
Yes,
microwave therapy and all are other ways of managing.
Non-surgical, ma'am is asking, non-surgical ways of treating metastasis.
yes, ma'am. Ablations.
Yes.
So mostly done in colorectal metastasis. So
Yes.
ablation, then microwave ablation, then radio frequency ablation, all these things are there.
Embolization, sir. Arterial therapies, targeted therapies we
Yeah.
can.
Those things are done in mostly in SCCs,
Yes,
tear
sir.
and TACE,
Yes, sir.
transarterial radioembolization and chemoembolization. They are more done in SCCs and some
Yes.
large colorectal metastasis.
Yes.
TACE is done. Yeah.
Yes.
What is, let us say this is an operable case. What
Yes,
is
sir.
a standard radical cholecystectomy? Explain the total procedure and the steps.
Yes, sir. Uh, sir, once all the routine investigations and optimization of the patient has been done, sir, we'll do staging laparoscopy for the patient, sir, and we'll look for any surface metastasis or momental deposits, peritoneal deposits, sir. Then we'll proceed with surgery, sir.
No, I know. I am asking you, what are the steps of a radical cholecystectomy?
Yes, sir.
What things you will remove and how do you approach?
Yes, sir. Sir, en-bloc resection of gallbladder with segment 4B and 5, along with lymphadenectomy along the hepatorenal ligament, sir, with sampling of hydrocaval lymph nodes, sir.
What are do you always do 4B5 or sometimes we do something else?
So non-anatomical wedge resection of 2 centimeter margin also can be done, sir.
Yeah. So it is always a radical cholecystectomy involves the gallbladder along with 2 centimeter wedge resection non-anatomical or 4B5 depending on the site of tumor. If it
Yes,
is more to the fundus, then you have to go for classical 4B5.
yes,
If it is on the non-fundic side, then you might get away with a 2 centimeter wedge resection. And then complete lymphadenopathy, lymphadenectomy, along with the hepatorenal ligament.
yes.
What are the station of lymph nodes in hepatorenal ligament?
Sir,
You know the
12A,
numbers? 12?
so
Yes.
12A, 12B, and
12P.
P, yes, sir.
12P. A, always remember A, artery, bile duct, and portal vein.
Yes,
So
sir.
ABP.
Yes,
Okay.
sir. Yes, sir.
Then again you have to go till the segment station 10
13.
along with the 8, 9, 10. Just like D2 gastrectomy, you have to go there. Then
Yes,
station 13
yes,
and
sir.
the retropancreatic. That is a very common.
Yes,
Lower
sir.
end of CBD and the retropancreatic node is very common. So that has
Yes,
to be removed. So, okay.
yes.
I think we can end. Dr.
What is the
Tangabel,
principle
sir?
behind non-anatomical resection?
Yeah.
Ma'am, a 2 centimeter margin.
What is the principle behind doing a non? Like when you do anatomical resection, you ligate the vessels and the duct,
Yes,
no?
ma'am.
What
Yes,
is the
ma'am.
basic principle behind non-anatomical resection? So that's called a Glissonian technique because it is based on the principle that Glisson's capsule, it
Yes, ma'am.
it kind of goes along the portal radicals.
Yes, ma'am.
So, yeah. I think you can wind up, sir.
Yeah. I think so.
Monisha, good presentation, ma.
Yeah,
Thank you, sir.
well done.
Thank you, ma'am.
Presentation, Monisha.
Thank you, sir.
Thank
Monisha,
you,
you want to ask,
everybody. I think.
clarify any doubt from our faculty?
Sir, yes, sir. Sir, in incidentally detected gallbladder malignancy, sir, is there any role for a prophylactic port site excision, sir? If the port sites are not involved, there is no port site metastasis. Even do we have to excise the port sites, sir, prophylactically?
So, as per the literature, there is no evidence to suggest that post-site excision will help in getting a better outcome. But usually, we don't have any history during the laparoscopic cholecystectomy. Usually, we don't get any history of how the gallbladder was extracted. So most of the some places they use the bag, some places they don't use, some places they take it through the umbilicus, some places they take it out through the epigastrium. So in view of all this, our consensus is that at least the site from where the gallbladder was taken out, that single port should be excised. There is no need for going for all port site excision. Single site excision is enough. If
Yes,
you
sir.
don't have a history of from where the port was taken out, then you should excise both the umbilical port and the epigastric port. Although mostly people take it from epigastrium, but I have seen surgeons, lot of surgeons, they take the gallbladder from the umbilical port. So these are the two sites. You need not take out the 5 centimeter ports. There is no evidence anywhere in the literature to say that port site excision has improved. And once there is port site metastasis, already the disease is advanced in that. Even if you excise, then the patient is not going to have any benefit.
Yes, sir.
You all
Thank you, sir.
faculty.
Thank you very much.
Thank you.
Thank you, sir.
Thank you
Good
very
night,
much.
everybody. Good night.
Thank you all. Good night.
Thank you, Dr. Kanagavil, sir, for the opportunity.
நட்டோடையே போயிட்டு ஆறு